I'll be talking about challenging situations with phakic intraocular lenses. And I'm just going to show you the way I do the surgery because it's a little different from what was shown earlier. And this is almost an unedited video, and you can see that it just lasts about 2 minutes or 1.5 minutes for doing the surgery. I don't dilate my pupils before the surgery simply because all of us had the experience that sometimes when you are doing your side port or main port incision cataract surgery, you touch the anterior capsule. And if that happens, you include that in your excess. But here, obviously, that's the end of the case in case you damage the lens capsule. So I like to have the pupil undilated during these surgeries. And this is the side port which is made up at 90 degrees and 180 degrees. I'm seated temporally. And once I do this, this is only saline I'm injecting, essentially to bloat up the eye. And then so now it's a 3 millimeter central incision that I'm doing temporally. And now when I introduce a mixture of phenylephrine and xylocaine, the pupil dilates very well in these young myopes. And that's actually cohesive viscoelastic that is going in, and you can see that the pupil dilates very well with this, and there's no pre-operative dilatation that is necessary. And the iris coverage of the lens capsule is something that I've got used to in the last 3 to 4 years. And instead of HPMC, what I use is cohesive viscoelastic like Helon. So as you can see, this is an absolutely unedited video, and this is a real-time video, and this is all it takes. And once you, basically I like to do the incisions of the limbus. No IA is used, but all I do is to hydrate my main port and side port incisions, and you can see that cohesive viscoelastic flowing out. Once clear fluid starts, because as Partha mentioned, it comes out as a bolus. And once clear fluid comes, that means at the end of surgery. And all you do is to just go ahead and inflate the main port and the side ports. And in case it's a toric intraocular lens, align the lens properly, and it works well. And I suggest that maybe you can consider these two tips: not to dilate the pupils beforehand, and secondly, to use a cohesive viscoelastic, which was not originally taught. And usually you end up with optimal results like was shown by the earlier speakers also. 500 microns of wall, 250 to 750, a well-centered lens with excellent results. But let us look at rotation of phakic intraocular lenses. When will rotation of these phakic intraocular lenses help? Is only situation is when the spherical equivalent of the residual error is almost zero. If you have -1 diopter with +2 diopters of cylinder, rotation is going to help because the spherical equivalent of the cylinder balances out the sphere as such. Because when you are rotating the lens, you are not, you are only redistributing the power. You are not introducing any power. So essentially, if it's just a -1.5 diopters of cylinder that's left over, or if it's a 2 diopters of sphere that's left over, then rotation is not going to help. Either you have to do a touch-up on the cornea, or you have to exchange the lens because this lens is not the right lens that has been placed. So as far as the rotation itself is concerned, do not hesitate. As you can see from a Varion marking, it's rotated by almost 17 degrees. All I do is no viscoelastic it introduced. It's just an irrigation cannula that goes in, and then with through the other side port which can be opened up. Usually I do it as soon as it is noticed. You just have to gently nudge the lens into the right axis. And it's important that with these expensive technologies, you get the optimal outcomes as far as your patients is concerned. It's again a couple of minutes procedure, and just in case the results are suboptimal and the spherical equivalent is almost zero, do not hesitate to rotate these lenses. Low Walton cataract, as you can see here, it's an eye with just about 130 microns of wall. The fellow eye has just 84 microns. But as you can see, the anterior capsule is absolutely pristine. I have quite a few eyes which have a low walt like this, but where the anterior capsule has been pristine, with the central flow especially, the propensity for development of cataract is quite low. And these cases can be followed up, and no need to rush into a lens exchange just because the walt is low, even though the ideal walt is 250 or more, and that's what you should be aiming at. And when you develop a cataract, Mahipal had already shown this, it's most often an anterior subcapsular cataract that you have. So extremely important that you strain the capsules because the anterior subcapsule is fibrotic. And you can explant the lens. This is running at double the speed. And by doing a hand maneuver, bring one of the haptics outside, then simply through the same 3 millimeter or 2.8 millimeter incision, you can get the lens out. The only challenge here is to do an adequate capsular access. And here, because most often these are highly myopic eyes, you need a good overlap of the lens optic over the rexus. Otherwise, the IOL power calculation itself is no different from what you will conventionally do. And this is a case of a extremely high vault. As you can see here, it's almost 1.4 millimeters is the vault, and 1.2 millimeters is the AC depth. Even more importantly, the angles are just about 12 degrees. Obviously, this angle is going to get zipped up if I do not do something about it. And the fellow eye of the same patient, here again, both these eyes were keratoconus patients, and now it's considered, it's not off-label, but it's an approved indication. You can see here again, the angle is just about 13 degrees, and the vault is too high, somewhat less than the other eye, but still quite unacceptable. So essentially, why this happens sometimes in the case of keratoconus is because if you have a central steepening like this, you can get as much as 4 millimeter anterior chamber depth. And the white-to-white measurements according to the algorithm is not only the white-to-white which measures the sizing of the lens, but also the AC depth. And when you have a normal cornea like this, but you have a central steepening in a keratoconus like this, you can get false values, because of which your phakic intraocular lenses may be oversized, causing a crowding over here. So whenever you are doing in a keratectasia or a keratoconus case, then it's always a good idea to undersize your lenses by 1 or 2 steps. If it's an Indian lens, by 2 steps, because it's 0.25 millimeters each step. If it's a ICL, then it's 1 step because it's 0.5 millimeters. Once we have started doing this, we find that this kind of oversizing with keratoconus cases is not there. And what did I do for that particular case that I showed you? Basically, exactly the same thing as the case with the cataract. It's extremely important that you do this exchange as quickly as possible, because if such a high vault is left as such, then you could end up with a zipping of the capsule, onset of glaucoma, which is a very difficult problem to treat subsequently, much worse than developing a cataract. Both the eyes of the same patient was actually exchanged in one sitting with a 0.5 millimeter less sizing, and it worked out well as far as the vault is concerned. And toric phakic IOL in corneal ectasias, this is a challenging situation. Initially, it was thought to be off-label, but whenever you find that with spectacles, you are able to get a good correction. You can have a centered cone. And how do you know it's a centered cone? You look at the posterior float. If the more than 50% of the cone is within the central 3 millimeters, or it's a very well-centered bow tie, then these are the patients who will do well. Just in case the patient needs a contact lens for the improvement of his keratoconus or the ectatic condition, these are not appropriate, rose scale lens or a scleral contact lens, because what the phakic intraocular lenses will do is what the spectacles will do. It is not going to take care of the higher order aberrations. So essentially, we have to make sure that the patient has a well-centered cone as well as a good improvement in the visual acuity with spectacle correction. These are the ideal patients as far as phakic intraocular lens is concerned. You can see this patient who had undergone an intact procedure with cross-linking, and subsequently for visual rehabilitation is undergoing a phakic intraocular lens implantation. This is an excellent way of you do the cross-linking to stabilize the cornea, put the intacts to center the cone. Thirdly, you put the phakic intraocular lens to rehabilitate the eye. And you can see a situation like this, again, where the cone is decentered. Because it's somewhat less, what I do is to do a topo-guided PRK. You can see the best corrected visual acuity is only 618. But once I do a topo-guided PRK, not only does it get centered, but the visual acuity also improves. And obviously a good candidate for this. And here again, 612 vision, pre-CXL intacs, post-CXL in intacs, you see that the amount of astigmatism has increased, but then the best corrected visual acuity has come to 6.9. So obviously a good candidate for doing the surgery. And just in case this is a post-DALK phakic intraocular lens, sometimes post-PK, post-DALK, you have a high astigmatism, even though the cornea is quite clear. And especially in a PK case, you have to be cognizant of the fact that the corneal endothelial cell count might be somewhat lower, but then you can rehabilitate these cases by putting a phakic intraocular lens. Last of my videos, and this is just to say that Partha and myself went to first started out these iris clip phakic intraocular lenses, and this is a patient who basically had an excellent visual outcome, was not willing to give that up, but the endothelial cell count has dropped down to less than 1,500. So essentially what I'm doing in this case is to remove this phakic iris clip lens, which is essentially a 5 millimeter overall diameter lens, and it's a PMMA lens. So I'm doing the two surgeries 1 week apart, taking the iris clip lens out. But since she was not willing to forsake the excellent visual outcome, I'm going ahead and implanting a conventional posterior chamber phakic intraocular lens. Thank you so much.